have an exchange program with this hospital and uses the for burn treatments. So in that case, what is first degree burn? Huh? What is first? When you say someone has a first degree burn, what does that mean? What is first degree burn? First. Huh? What is limited to superficial? So basically, first degree burn is what because someone is like, you know, I know most of us in this part of the world because we have dark skin. So first degree burn doesn't really apply because back at the first degree burn, you might not notice it on me because my skin is dark. But if someone like a child has a first degree burn, you're going to notice it right away because first degree burn is anything that is not blistered but has blemish coloration on the skin, which is more like you're close to the fire and you're walking, you feel that heat. And that whole area kind of turn a little bit color, changes. That's a first degree burn. The skin is intact. Nothing is open, nothing is blistered up. That's a first degree burn. And then second degree burn goes into what? Second degree burn? Huh? So second degree burn is once the skin is open, when there are blisters, you see the whole coloration. The skin is open, the skin is blistered up, that goes to be a second degree burn. For us in medical, in bone world, we have what they call first, second degree superficial, second degree deep, deep tissue burn. And they go to, I'll break those down as we go through. And then you go to third degree burn. Third degree burn is when the whole skin is peeled off. It becomes, slippery, it becomes pinkish, it becomes pale. You see, even here, third degree burn is where the color of my skin does not matter anymore. If I get a third degree burn, the same color I have is going to be the same color you are looking at. If the child has a third degree burn, it's going to be pale, white, leather. Because the coloration you and I has that makes you black and makes this guy a light skinned guy is the outer epithelial that covers us. Outside this, everything is all the same. Inside. So that is third degree burn when the skin is slippery, pale, and leathery. You see something third degree burn. I have a picture of someone with third degree burn is all you rub your hand on it, it's still like leather. It's very leathery. You don't feel the skin. That tells you that everything is gone. Blood vessels, capillaries, veins, that's all propelling or producing blood to the outer skin. Everything is there. It's out. So the few of us, as we go through what we call the TBSA one. TBSA one is for the total body surface area, where that one is. In the US, we do what we call the Packman formula to count how as percentage. The TBSA will go by 100% from head to toe. And we do the counting the size of total body surface burn with the size of your palm. So for physicians here or nurses here that will work in the burn ward or system on the street. So the size of my palm is 1%. The size, and for that depends on the size of each person's palm. The size of my palm might not be the size of your palm. So if you have a patient, for example, that has burn, can I use an example? Yes. So that patient comes out, let me use him as an example. Right now, the size of my palm will have the same size of palm, right? Probably. So I'm going to estimate my size of palm to do the percentage count on it. We're going to go into the logarithms of how you count that. So you look at his head and you look at the face, everybody here. So we do what we call the TBSA. That 100% burn, we massage and go like this. But that's what we call an estimation of the burn, which runs from here. That here gives you 18% of the anterior torso. Then the posterior torso is also 18%. If you can calculate that, that gives you both the front and back, gives you 36% of the total body surface burn. And then the same way goes for the head, from the arm, from the shoulder right here, down to the wrist right here, is 9%. And then the size of the palm, the back of the palm, and this 1% is 1%. If you calculate everything, that is 100% total surface burn. But that's going to depend on the the size of every individual, size of palm. So that's how you have what we call the TBS, the total body surface area of the bone patient. What is the principle of fluid resuscitation? We use the Partner formula. Is there any doctor here? Anyone here in Sumatra? Yes. Okay, so we have a system that we use in the United States. We would by calculating the age, the height of the patient, and then you have to calculate that to know how much fluid resuscitation. I don't know if you guys do fluid resuscitation of patients here. So you have to calculate that to multiply it by 2 to the size, the weight of the patient, and the flow. So you know the fluid intake that patient is going to start resuscitating that patient. And we all do that on resuscitation of one patient study start if you have more than 20% TBS. Anything under 20%, you don't resuscitate that patient. So resuscitation starts on 20% TBS up. So that means the patient comes in with anterior body surface bone from here, that's which is 18%, and I get my arms, it's around 9%. That patient will be resuscitated. So you look at that percentage, but at that point in time, you calculate that person is losing a lot of fluid, and lost blood, and plasma. Everything is gone. Like what I remember Dr. Stephanie's lecture yesterday, you have to look at how much blood the different system of within a 4-hour period that person is losing. That patient will die if you don't do anything. So you go into that. Then I'm going to go into NBA result criteria. Let's go to the next slide and I'll come back to this. So NBA, one of us, we go through that. The third degree leads to accidental death in all ages. Third degree one is, which is once you get to third degree, it has to be intervention. Burn is something that your life is at risk. With a third degree burn surface area of anything more than 20%, you have to take that patient to the hospital right away. We have what we call like immediate intervention for the burn patient. On the field, we have a system in the United States. Once a call comes into the radio room, or accident, or house fire, or cooking, that patient will be rushed right away. There's no sitting down on the road. There's no sitting down on the kitchen. You have to take that patient away to any burn center. That is the only way that patient life can stay. Because at that point in time, blood pressure drops, right? What else drops? When your skin is gone, what do you lose? Heat? Electrolytes? Exactly. So time is at the essence with one patient. Somebody can have a gunshot wound, like what we did yesterday, stop the bleed. I have a last patient. You apply pressure, you put tourniquet, you stop that bleed. God is not like that. God, everything basically drops on you. If you don't rush that patient to the hospital, that's the end of it. So third degree burns is what, because the whole thing with third degree burns is you don't intervene. You're going to have, that's what we went yesterday, that patient going to need probably escorting. Especially what we do to release the pressure. Because once your skin, what happens to heat, heats everything in you. So the skin gets tight. And the skin gets tight, all blood vessels underneath the damage, the tissue, start compressing. The blood vessels start flowing. If you don't open that part where that blood is to release the pressure, you're going to contaminate syndrome. And once the contaminant syndrome sets in, they're going to shock. And they're going to die. That's a fact. So that's why with burn patients, time is of the essence to rush that person to the nearest burn hospital or any place where that patient will get immediate assistance right away. So that's that. So you look at it, it's like 2 million people a year are burned. That's a fact. I think I can see here in Nigeria too. 80% of those with less than 20% TBS, I said, the number is 400 from fire stroke inhalation. Let me talk about inhalation. Number one thing that kills burn patient is inhalation. Your oxygen saturation goes right away. Once we have that, You might even have like a 1%, let's say 2% burn, but like an enclosed area in a house with that is locked at night. You help that smoke, your chances of survival goes down. So if you look at the statistical data of this, like us at UCSD, we have only 450, actually that percentage is more. Every year for burn patients, from ulcers, from chemical, from stubborn is water, hot water, from fire. So all this is we get every single year. Children 5 years or older or younger, have some half percent of our percentage of burn patients. We get a lot of children, parents are cooking. Like in the US, you give a hot water or soup or coffee, or you cooking with oil, you leave it on the counter, and that child cross there and pull it out. We get that a lot. They are not going to spill. That's what we do in US of burn prevention of children. It's the #1 pillar of little children in the household. So when you are cooking, you hot water, soup, whatever it is, keep it away from the reach of children, because children have a mind. They want to touch. They're inquisitive. They want to see what that is. They go there and they grab it, and their life changes forever. Get away from the kitchen. Or people that have gas stove in your house, when that gas stove is on and you're cooking, try to turn away the handle of that thing you're cooking to the back of that stove so they can't reach it. And always make sure that your panel, your lineup is up when your children is at home or little children in the house. So that's how you have that percentage of burn. So 100,000 outpatients almost every year that we have. This is with UCSD, statistical data that we have. So look at this. So we are going to spot burn. So non-burn patients, spot burn, as I said, is hot water. Anything is burn that will touch you. So what is the burn temperature? What's the boiling point of water? Yes. Huh? Yeah, 100 degrees there. Okay, we do 120 back home. So we do 120, so 100 degrees. So, and let me tell you one thing. Go home, try this. 120 to 100 degrees of hot water is nothing. Because touch one hot water, take a thermostat, test it, and see what it is. That hot water, touch it to yourself and see how hot it is. Then imagine a small child. Our palm is one of the thickest part of our skin. But you take that and touch any other part of the skin and see, you get burned very easily. But that's the boiling point. So the reason why it gets much like when you are boiling, you cook it on a hot stove. That temperature of whatever you're cooking, soup, or whatever soup it is, or oil, goes up. Most of it goes to 400 degrees. Depending on how the mix or whatever you're boiling. That's why the stubborn gets through. And then you go to electrical burn. I don't think there's electrical burns here that easily. For us out there, we get electrical burns very easily. People touching high tension wires or transformers. That is exactly 150 degrees. Chance of survival is very slim. And if you survive the initial impact of electrical burn, you come to the hospital, that whole tissue, because how electricity is, if I touch an electrical current, anything that you're saying like 350, 200, 350, 450, 5,000, once I touch it, it starts in, it flows, the electrical impulse follows your blood flow. The entrance wound might be here, but the exit wound might be out somewhere else. Or you can travel all the way because you're following the whole blood supply channel. So that's one thing. One thing that all the part that electricity current is traveling is destroying all the tissue. It's destroying blood vessels. So that's the danger of it. That's where electrical burn skills. Then you have flame burn, which is burning bushes, burning grass, burning people fell inside it, dangerous. And then structural car fires happens a lot. You driving your car, somebody hits you, and you can't get out, the car explodes. You're gonna get burned inside that thing if nobody comes to get you out. Because one thing you don't understand with cars, with auto vehicles is once an impact, especially with heat, the doors jam. You can't open it from most of the car from this side. Most of the new cars they build now is basically like locks itself. So somebody either you have to break the glass, you have to try to get out of it. Structural tower, welding, propellers, explosions. I know we have it here now. You can see that. There are cases that someone called me here few months ago. I think some lady in Lagos was cooking with propane tank and had a phone. She got almost 100% gone. They sent me that about that thing. I said, unfortunately, that's too late. So, and the problem with that is that this lady got gone. They still have him in the house for almost like 4 or 5 hours looking for a vehicle to transport her to the hospital. It's too late. So she didn't make it. So that is propane gas, stay away from, make sure when you turn your propane tank gas cooking. Turn it first, listen for sound of gas leak. That's what kills us. You turn your cooking stove, listen for the sound of gas leak. You hear a noise. If you don't turn it back on. And then if you use it like a lighter or matches, stay away from your lighting because once that gas, you turn it on anything, you go to it's air, it's inflammable. That's why it's gas. Anybody around you is going to be toast. So, and then open flame. The chemical one is chemicals are something you stay away because chemicals, you touch sulfuric acid, you don't want to keep running. Deep into the tissue, the powder, all chemicals, stay away from them. That's why you see people that work with chemicals on the ground, all these industrial gloves to protect themselves from damaging your skin or touching you. Lightning strikes happens. They say 1 in 5,000, 1 in 5 million, but it happens. Depends on being at the wrong place at the wrong time. Lightning travels in a straight line, they say, right? If you're on that part of that lightning, you're gonna get hit. If there's any current, a car, a vehicle, a tree that transforms, current, and you're next to it, you're gonna get you. That's what lightning is. So stay away, like they say, lightning. If you're walking outside of the rain, it's raining, always wear like a rubber shoe. Don't wear heels that have iron on it. If electrical current falls, it's high tension wire falls, and you're walking out, even with water. The flood water is active current that's going to zap you. By the way. So self-inflicted suicide, that's the whole different case. People do it a lot. I don't know about this society, but where I come from, people get tired of life for some reason or the other, and therefore that's themselves on fire. It happens. Suicide, people with intentional suicide, people do it. And then smoking is one thing, people especially get a lot. Smoking and passing out while you're asleep. Smoking, you get some drink, you're drunk, and you smoke cigarettes. Once you're drunk, your memory, you retarded, basically. And you have a cigarette in your mouth, you have fall asleep, and that's the end of it. By the time you wake up, you're 5 minutes. That's simple. So stay away from that. Back to where you say the elderly people have emphysema, people have very hard breathing problems, people that are oxygen concentrators or have some breathing issues that walk around with oxygen, help them survive, and they smoke. That's a danger. Don't do it. So look at this one temperature here that we have. Look at it. This is the estimated length of time that you can get how keep sugar. Water temperature 156 degrees will take a second of touching you, and that whole place is gone. 149 degrees, like I said, when you get home, get a thermostat. Check the temperature of when you are cooking. You'll be able to assess this one I'm telling you, realize how dangerous we are in every day of our life. Yes, it hasn't happened to you, but it does happen. And don't be one of those because you can take precaution and prevent it. So you look at that, smoking consists of combustible products, as it just ended carbonation techniques. So you look at this guy here. This is the patient. This is intentional suicide. The gas himself. So he survived, but life changed. So patient like this, you see that the first thing we do with your whatever for physician It's about inhalation injuries. With this kind of burn, everything, if you look at his mouth, the burn goes down all the way. And that's what kills them. If you don't intubate this patient right away, that's what we do. Come to the hospital, you have to secure the airways. Because within minutes of this burn, the airway everything will all swollen. And once the airway is swollen, you can't get anything out from here. You have to go, open it up. And depends on how bad, how fast it goes, or how deep it goes. So intubation number one, you see that in this mouth, that's also people that parental officials are very, very, very important that you need to protect their airways. The first thing you do with patient burn, mechanism of burn, where, how, age, where were you, what happened, did you fall? With that patient, most times with burns, they get disoriented, they fall. That's where the trauma comes in. They hit their head on the ground. You have no idea what happened. You have to secure the neck, the sleep along the way to protect the spine before any treatment. Intubate them and go from there. So patient with impaired, sensory agitation, we get out to looking for, hoarseness of the voice, tachycardia, and dysphagia of that patient, disorientation, difficulty breathing. So, like I said, burn is something that's actually one of most cases say in US, like you can have a gunshot wound and they go get taken out and survive. You go home without pain, right? Usually, when you go home, you get burned. It's a long process pain control that you're going to go through. Look at the next slide. So these are all inhalation injuries that what we do, once that patient is intubated, you have to block that person. You have to keep suctioning all the dead tissue inside that person's out from the airways down to the lungs. So you see different stages of normal airways and then inhalation little by little down to the trach, where trach, breaks apart into the. You see something like this and something like that, chance of survival, adversely. Complete suction period of that person has to be brought almost. We do brought almost every day. Because you have to keep bronching them with continuing of the airways. Next. So this is the statistical data of carbon monoxide poisoning. Carbon monoxide, you know what carbon monoxide is, right? Okay. Carbon monoxide is for odorless, right? You can't smell it. And that's why it's deadly. Carbon monoxide, every house in the United States of most houses are all equipped with carbon monoxide detectors. The whole idea in the house have a carbon monoxide like you have fire detector alarm. That detector is there hanging. You're sleeping and something goes wrong in your house and you have carbon monoxide leak there. Because you're sleeping, you sleep dead. That's what it is. There's nothing to say you sleep dead to that. And most of that are caused by smoke. So before that sets up either electrical wire or pistol, something starts the fire. If you don't have an alarm system in your house and there's no, because carbon monoxide detectors is very loud. What it detects is an alarm system. You wake everybody up in that house. That's why it's very, it's very important in the US household. It saves life because if not, everybody in that house, nobody walk out. That's it. That's the thing. So let's go to this is part of physiological carbon monoxide poisoning. The hemoglobin because it's not the whole red blood cells. That's why it's dangerous. So red blood cells of 200 more penetrative than oxygen. This is a cellular respiration. So slowly, the earlier intervention, the faster you get to that patient, probably more chances to have saving that patient's life. There are families living in the house, carbon monoxide poisoning, everybody's there. Because you can't smell it. It's not like you're smelling ammonia, you're smelling bleach, any other chemical. No. You're sleeping, you're breathing, and that's in the face. So these are things that physicians that you look into. Look at the system you guys have that will start this because each of these saves life. That's the whole listen. So this is an analysis of 5% of carbon monoxide poisoning symptoms. This is traumatic mild headache. Those are signs you wake up in your house and then you wake up and you're having a little light headache at night. and you have no idea. Everybody having the same symptom. Something is wrong. And then 5 to 10% is very small to do that. The 11 to 20% dizziness, nausea, dyspnea, flushing. That's sign you look into. The 21 to 30% visual disturbances, you can't even try to figure out whether you're still only one person or you're not. So all these are symptoms. By the time you get to 50% or above, cardiopulmonary dysfunction, chance of survival, basically drugs and goes down. So this is a patient that will have a carbon monoxide poisoning plus the fire. So that happens to this patient that has supplemental oxygen is a key. You have to give that person air. Every hospital in the US is equipped with oxygen. Every bed has oxygen for the wall that we use. So once the patient comes in, you plug it in and hook it up. That's only because the whole idea is that you have to get the bad air out, you put the oxygen out to exhale. So you try to clean up whatever is inside, and you do that every day. Then you bronch that that should be out there. And then as you're doing it, you're treating the bone, the body is on the skin. So most of our patients with oxygen, with carbon monoxide oxygen, we have a hyperbaric. I don't know if you have a hyperbaric machine here. So hyperbaric is a machine that is where you send patient with carbon monoxide oxygen to hyperbaric. They go through it, they go there every day. We call it a dive. It's like a space wall. You put them inside there, you can be there for 2-3 hours. If you have all the blood, and then get it, whatever they did, blood, the dirty blood out, the contaminated blood out, the air circulates, they stay there, they come back, they do it every day until we tell is over. So this is the analysis for bone wound death. Like I started earlier, a lot of superficial bone first degree, partial thickness bone second degree, that we break it down to superficial partners and deep tissue bone. This is analysis of our skin. If you look at the way your hair follicles comes out, that's the hair shaft, and then that's your epidermis, the outer skin, and then you have the epidermis, you have your oil glands, and then you come to the subcutaneous tissue at the bottom with your lymph nodes at the base of that, at the base of your dermis. So by the time you get to third degree what we call food thickness bone, by the time you get to third degree bone, most of all these here are gone. So you go into fourth degree bone, which is deep tissue bone, is the muscles. You see people that get body bone in the hospital setting. Sclerotomize the skin all the way down, all the tissue. You see the skin, you see the tissue. What we call the meat, the red meat of us, it's all being dynamic, it's all purple. It's all brownish color. That tells you how deep that burn has gone down to that tissue. Let's go next. So this is typical from our beginning. This is what our first degree burn. For us in the US, where people go suntan at the beach, outside, this happens a lot. You see that lady there? You see the face and this guy. This is the lady that was at the beach, facing down with the bra on. You see where the side bra, but the rest of her body, that first degree burn. Do we treat this? You come to the hospital, we give you vaccine, we give you corresponding ointment to go home, rub yourself, and stay away from the sun. Don't go out there again, because our skins are very light. For you and me, probably you might not have this. You can stay, burn yourself outside on the sun, which you guys have there. You wouldn't notice it, you wouldn't say it. So let's go down. So you see second degree partial thickness burns. Look at this, look at that, look at the tie here. You see how the skin is up. You see how pocket of blister from that first degree burn on this lady. From some burn, most of the skin started opening up. Same on that. Once the skin opens up, it goes into a second degree burn. Let's go ahead. So this second degree deep tissue, you see a correction here, what we call full epidermal involvement, deep double. You see that? The flag shoulder there. So that's what we call skin blanching. We need them also. If that patient is here and you press your hand on that shoulder, There's what we call capillary review. Capillary review tells you how deep the areas that are deeper than the rest of them, the areas that will need surgical intervention, the areas will take that patient debride it, go through the debridement process before skin grafting. So if you press that skin up here or this guy here, you press it down, you let go. You see blood refill, you turn pale white, you let go, the blood comes back. That tells you that capillaries are still alive, they are not destroyed. That's a good sign. But when you press it and it stays the same way, no blanching, no refill, then that's there. From there, we assess, because most of our patients have it in the bone unit after they train or gone to the surgery. We're going to start putting that testing on so that, and we start putting. So this is deep, but okay, let's go to third degree bone. Okay. So this third degree bone, see this guy here? You see how the whole anterior torso is? This is all leather. So the little remnants, the little dark areas, that all put in as well. There's a scar up here, you can see a little mark. So if you touch that patient, you touch him, you don't feel it will hard. That's what our skin becomes leather. You touch that patient, you know what you're feeling there is the milk and the hormone. That's what it feels like. Basically, that's how when you burn it, when you burn that, that's what you feel it. It's all there, it's all gone. All those things has to be removed. So we take that patient to surgery, usually by the 5 or the 7, surgically exercise the whole thing out, move that whole skin, start putting aloe, which is temporary skin covers to start mimicking growth on that skin for survival. Next. So certainly I put thickness bone. Okay. This is a typical example. If you see that guy here, that looks pretty much like an electrical bone. But electrical bone burns deep. You see how like a roasted is, because once the contact is there, it burns. That area is burned. That might be the exit wound or the entrance wound or exit wound. Usually the entrance wound don't burn that much, but the exit wound burns more. So if you touch it with his hand, it might transfer, transit out to the back and exit out, and the current comes out from there. So that's it. This is a guy that was soaking his feet on a cold environment, his feet on a hot water, and doesn't have blood perfusion on his lower legs. You put your legs there, if you're diabetic, one of those, you are neuropathic. Put your leg there, the water is warm, you enjoy it. By the time you leave your foot there for 30 minutes, you come out and it's going to be different. That's bad. So that was the information, of course. So in most of these cases, you can see a second degree bone and a third degree bone conversion. Third degree bone conversion is the first time when someone gets burned, no matter what the mechanism is, there's what we call a 72-hour window. 72-hour window is for that burn to define itself. That means whatever the process, whatever the mechanism of that burn is burning deep into the tissue. It will take 3 days for you as a surgeon or you as a nurse to say, okay, wow, this is where this burn is. The third degree burn is third degree burn is kind of levels out. So starting testing of us back to where we started, this is what we call the rule of 9. The rule of 9 is percentage of burn with the size of the patient's palm. So look at this chart here. This size of palm has of palm is not going to be mine, right? So how do you assess the percentage of burn? Sometimes it's difficult, but you have to estimate. If you look at his size of his 9, if that patient comes to you with one side of the arm burn, and this is not, and you look at it, okay, from here to here is 9%, you estimate that about 4.5, right? 4 or 5%. So compared to if you can estimate, usually for kids, we use like a thumb of a hand and go 1, 2, 3, 4, 5, 6, estimate it up here, not the whole side of arm, to get the percentage estimation. But adults, you look at it, you look at the side of the head, there is 9%, and then for 9%, the side of your whole head, your face, and the back of your head. Then you look at the chest, your anterior torso, from here down here 18, the posterior is 18, the arm, here is 9%, your arm, your hand is 1%, and then your legs from the femur right here down here, give you another 18%. If you calculate everything, It give you 100% TBSA. That's why we calculate the percentage upon the patient. And that percentage upon helps you to calculate, to know how much suspension that you're going to give, how much food. And that helps you also on the medications you're going to give to that patient to control pain. Number one cause of death in patients, one patient is pain. Pain. The US we use on the first time we put them on fentanyl, or when they intubate, they put on propofol. Ketamine, we use ketamine concentration. We don't use that much. We want those most patients, because ketamine is fast, it's fast, doesn't last that long. It wears up and they go to the moon and they come back. The pain comes back. Propofol stays there, slow, gradually controls the pain. The propofol drip, and that gives them asleep. Most of our patients that comes in the burn unit with any pain more than 25-30% burn, we intubate them and put them to sleep. You put them to sleep like induced coma, and they can be there for weeks and months until they go to sleep. Because number one, you want to control that pain. You don't control that pain, they're going to shock. You don't control that pain, they die. But the pain threshold, with the point, everything your body system shuts down. So what's the survival rate plus size and age? So this is the survival rate that we have. If you look at the bone size of 5%, 15, 25, 75% bone, the more it goes, or you look at the longevity from 20, the survival rate to 100%. The higher the percentage of bone you have, the chances of survival goes down. Especially when you're out in the field, especially when you don't have advanced level 1 trauma bone center, where you can intervene on that patient. We have 100% bonds. Even before I left, we have 4-5 patients in my unit that have 100% bonds. They're all alive, they all go to sleep now. So, bone shock, internal injuries as obligatory bone wound edema, which is unique to bones. So, if you look at this, so this is what, if you look at the capillary permeability or electrolyte imbalance, this blood flow. All this is things that we say that bond is one thing that we don't see that much, we don't account that much. And that's the reason why it kills. Especially out here in the rural area where you have all these people most of the time in cooking at home. I have experience last time I came, we were up at Owerri, and this lady got born, they were looking for a pickup truck to put her to the hospital. They get out of the hospital and go there the next morning at FMC with us for the body. She didn't make it. I'm like, why? And her percentage of bone was not even that much. But when I saw that they put at 25 or 30%. But the thing is that they have the methods, they have the equipment, they have the means to keep that patient alive. The answer is no. So these are things that we have to fight for here. So let's go next slide. So this is part of our whole partner formula, they go to maintain adequate tissue profusion. That's the key. Profusion. You have to maintain adequate, profusion of blood flow to keep that patient alive. And once you get that, then you have a chance of that patient survival. And one patient, we have patients in my unit that call that 60% born, 70% born. They stay with us, they stay in the hospital for 1 year, but they go through subsequent skin grafts. So they stay there until they get better and they go home. So it's not something that they come in next week, next day, they go home. That's what happens. So this fluid resuscitation, this are mainly for physicians. So this is what I was trying to explain at the beginning. So if you see for adults, we get a percentage of the TBSA body. This is very important for medical students. I want to take picture of this because I know. For TBSA body, the total body, the weight, the percentage, times the body weight of that patient, multiply that by 2.4. That is the milligram of the alarm going to start inducing into that patient. Give the first half over 8 hours. This is the UCSD prospect of formula that we do, and it's modular, American Board Association, ABA, or to try the country. So that's for adults, and you do that for 8 hours, and then follow the next round of 16 hours. because the blood patient is maintaining the fluid balance for patients because they are losing everything. They are bleeding, they are progressing. If you see where a blood patient is, the everything is sitting out. If you don't replenish that fluid, that patient, that's the end of it. That's why they die. Because next, so the second root suspension, patient with 20% TBSA root suspension due to compensate for pulmonary edema, fluid loss due to the burn. So 15% should be able, less than 50% should be able to bear, give an IV versus giving treatment. The 20% TBSA may not require fluid. Depends on how deep that burn is. But 15 to 20% of deep tissue or full thickness burn is not the degree burn, you will need fluid, you will good at the suspension level. So most of these are basically the Latin region that we use to allow for different percentage that you're going to use inside the hospital setting. When the patient is intubated with an IV, so you calculate that and you're going to have how much fluid that's given that patient for survival. So the calculation of the percentage of the burn by the patient weight gives you an accurate to measure so that you don't over sustain that patient and so you don't under sustain that patient. So, okay. So this is basically, IV fluid of the patient. This is, the precious infusion function. Most times, our patient comes in when they have full thickness burn. You can't get veins. You can't get anywhere to put, get IV on there. We do that. Monitoring blood resuscitation, blood, resuscitation fluid, the same thing that went through, blood pressure, pulse, urine output. Urine output is very important for our patients. You have to, because they don't need. Number one thing that goes down on blood pressure is renal. But they're not paid. The kidney stops. Everything is all stuck in there. That's why we do output check. Most times, we have 2 hours, see how much they're paying, 4 hours, we send it to 8 hours, see how much they're paying. See how much is coming. Although they have a cat in the back, a folio on there. You have to make sure that folio, see how much urine that's coming out. So this is a typical transport system that we had at UCSD. This guy was there, this lady was airlifted. So it's a whole different world we live out there. In UCSD, we have 2 helicopter pads. We have fly in with patients. Any patient that we have anywhere around San Diego, more than 30 minutes away, road transport to the hospital has to be airlifted. They airlift them or helicopter, to the hospital and they come into the. So this is a partial thickness burn criteria for American Blood Associations, greater than 10% TBSA, 3rd-degree burns in any age group. Burns that involve the face, hand, genitalia, perineum, and major joints, electrical burns, chemical inhalations. So children, born children, you go to this whole criteria, and then for the patient. So this how to transfer pre-hospital patients. I'm sure most of this, that's what we call scoop and run in the world of burn. In the world of burn, scoop and run is paramedics. 911 is called. Paramedics pick up that patient in the field at home, wherever it is. The first thing we get an IV if you can. Pain control if you can. Morphine when you can get that patient control, and then as you are doing that, the ambulance is moving. It's not stopping in one place. You are moving. You have to get to the hospital as soon as possible. The hospital. You don't stay, you don't meditate, you don't do anything on the field. Because the time you lose that patient, by the time you waste, you're killing that patient slowly. So these are all, and then when it comes to chemical burn, so chemical burns is any part that whatever chemical, the number one thing is irrigate. If somebody, powder spill on the face, irrigate that patient. You save their eyes. Have a flush. If you don't have flush, bottled water. Put that patient down and keep, washing it, rinse it out. You'll be able to get all those chemicals out as soon as possible. So stabilizing the patient. This is the ABCD we talked about all day yesterday. Airways, number one, airways. Without airways, no breathing, that is there. Spine control. Number one question we always ask our one patient, did he fall? What happened? How did this happen? Once they tell you, oh yeah, he was knocked out, or he staggered, confusion, and fell. See color. Just protect it until that patient wakes up and tells you, hey, move your head, move it back and forth. But before that too, we do subsequent CT scan. We do scans, to make sure that nothing, and that will be ruled out. There's no C-spine involvement. The disability neurological deficit. So these are all the processes, that we take. Every hospital is different, every country is different, but for us in California or in US, we have a standardized system that we go through for all patients. So these are pictures of the patient airways. You see that with the, look at this patient from day one. I think this picture was taken, I believe, day 3. You see how small it is? No, actually, this picture was taken the second day after it was debrided. Debridement is where we call manual debridement, that you clean up. You have to surgically scrub all that skin, all that burn area off on that patient's skin. You have to remove all that dead tissue. All that skin is there. The more you leave it there, the more they get infected, the more the pressure testing. We fight, number one thing you fight in the blood pressure is the infection. Once the infection testing, everything you are doing is being at the backbone. So look at another picture we have here too. So number one thing, so this is experiment. See this picture here? That you have to release the pressure of the head of bone within the first 24 hours, or else contamination of testing. You release that so that you have provision of blood. The blood vessels opens up and start flowing. If you don't do it, they get contracted, and you have get a folly. This is a key that get born in the space on the mouth. So the same process have an NG tube to help your feet. Most of the patient comes in with special bone can have a tube for them to eat. With next. Headache control. I know you guys have what you guys use here in terms of medication. So for us over there, the EMS, which is the paramedics of the field, always get an IV, start the first pain control on that patient before they get to the hospital. And once they come into trauma bay, we take over. So it's a whole different process. And then we do our own assessment of that patient and then pick up from there. So transfer of patient goes so let's go to debridement blisters, necrotic skin, and foreign bodies. So debridement, which is like a second degree bond, get all the blisters off, scrub it off. Necrotic skins, you see where the wound is bad, you get off foreign objects on the skin. Never remove it, like I say, on the field. If it on that when it comes to the trauma bay. Whatever the object is, whatever is launched, stop on that patient with the blood, leave them alone, they go to the hospital. So most of the patients that we do on biological agents, not of what we call wound dressing, a whole broad view of them. Most of our patients, we put them, corresponding ointment is like neosporin, the most basic second antibiotic ointment that we use. But for deep tissue bonds, we use SSD. I have some jars I will give to Dr. Ige, probably in the bond area. It's one of these, it's a cream that we use. What it does is it stops, you just have to put it up on the wound. We do it the first 3 days. It stops the wound from penetrating, stops the burn from penetrating deep into the tissue, so that it stops. That's the 2-hour window we have for the wound more than metals that are stuff there. Then after that, we have a lot of things, that we use, depends on how bad the wound is, depends on how dirty the wound is. So in most cases, for you guys here, you have a patient, if someone that get burned, number one thing, the best thing you can do to that patient is cover him or her with the warm blanket. Cover that patient. I see it here a lot. People get burned at home on the street. They leave their body open. Everybody's running around, screaming and jumping up and down. The best thing you can do to that patient is get a blanket, get a warm blanket before transport that patient. You have to get the heat on him or her. So this is some of my cream I was telling you, this is SSD on that side. Santion is one of those, it is a collagen, it is an enzymatic debridement that works a lot for second degree, third degree partial thickness burn. It's an expensive tube. The tube of that is like $400 in the US. And it's only one company, so you probably know. You can't see it here because I tried to. It's one of those that controlled by the company that does it that sent to the burn unit. So these are other things in terms of dressing wood that we use. We have a lot that we, I've got samples of these I'm going to distribute probably in the burn center out there. So this is experiments and partial that we do. So that saves life. We can do experiment of partial on a patient from head to toe, depends on where the thickness of the third of the deep tissue bone is to release the pressure on that patient. And then because it helps also for the fluid resuscitation of that patient to basically, the patient be able to accept it and work for him. So these are the route when to call a hospital, when to call the hospital anytime the patient returns to hospital. Anytime you have a patient got born, please don't leave that patient out at home. Don't leave that patient on the street. You can be the good Samaritan. Even if a life you save can be yours. Whatever it is, transport that patient to the hospital. And then so that the physicians can start. So this is just a 38-year-old man involved in a flashback when he attempted to light a propane tank and exploded. He weighs 88 kilograms. No other trauma or evidence of inhalation versus stability. So on this patient, okay. On that patient, that's okay. On that patient comes in, the first we done 8%, the first thing we do is number one, what happened, find out the age of the patient, what happened, making some of the burn. And then that gives an idea of what else to do. We are next to. So because it brings you back the whole paragraph. For that patient, we have 40% TBSA, we have an 88, that was 88. Multiply that by 4. This is how much fluid you're going to give that patient for immediately of an hour. Okay. So this oil, start burn. Someone that's filled grease oil, hot oil on the hands still. These are all thickness burn. You see how pale white the first thing is? The first thing we do is, release the pressure, experiment or partial, release the whole pressure so that it will expand before. And then inside that treatment right now, we start with SSD. SSD with bandage and gauze, and wrap. So that's one thing. So in time before we go to questions, there's some I know every country is different. I know for us in the US, we have what we call skin grafting, procedures where we use allograft. There's a lot of things that we use for skin grafting. One is allograft. Allograft is cadaver skin. People that donate their body when they pass, we use that skin, we degrade that skin, process it, and then use it to treat other people. And we use xenograft. Xenograft is pig skin. We use that too. We use that skin, process it, and then use for temporary skin coverage. And then before autograft. Autograft is the only, remember the skin. Our skin is the only organ in the body that cannot transplant. That's the danger of burn. Skin is the only organ in the human body. You can't transplant my skin to him. You can't transplant my skin to him. If you get 100% TBSA burn, you have to maintain treatment on him. See where it's not burn. Most times happen that comes in with almost 80% burn. It's only the scalp, the head is not burn. We shave him or her, we can get the scalp more than 10 times because the hair grows back. Our head has blood, flowing. We take it, 3 weeks, we go back to it again. That's why they stay longer. Another thing we have for people that have big burns, that we take a DNA culture, send it to a lab in Boston. Jensen, they grow the skin every cell. Every cell is like donor, it comes only from that patient DNA. It's an expensive process, but it gives us like you can have like a 4x4 or 6x6 sheet, and you spread it, you come up with the whole arm, and you wait, you take another quarter, and usually it's a process. So that's why people with burns, most times don't survive because of you can't transplant their skin to someone else's skin. Any questions? So the whole reason with burn is one of those part of medicine that is special. It's a specialty course, a specialty process because we all live every day, we all walk every day. You never know what can happen the next step that you take at home, on the street, anywhere. But if you know how to treat and what to do, what's early intervention, even if it's a 10% burn, even if it's a 1% burn, you can save that person's life. You can make a difference. All right? Thank you.
Hello, everyone. You're all doing okay this morning. My name is Clarice, and I'm actually a physical therapist, and I work at San Diego Health. We're going to talk a little bit about burn rehab. We have these amazing people over here that work in our hospitals, and they save their lives, but what happens after that is what I'm going to talk to you about today. So we're just going to talk about goals of therapy and interventions, talk about mitigating risk for contractures, which is a definite issue with patients with burns, talk about best practices for positioning, splinting, safe range of motion, and scar management interventions. Let's start with this because it really talks about how rehabilitation is something that you do in the hospital, but it actually continues for months or years and after they leave the hospital. And the idea behind this is that it's not just the therapist that does rehab, it's not just the patient, it's the actual team, because what we need to do is instill in the patient and their family that this stuff needs to happen, not just for them when they're in the hospital, but ongoing, sometimes for the rest of their lives. So it's really an education thing more than. So goals of therapy for patients with burn injuries specifically, there's a few things up here, we want to reduce the edema and pain. Range of motion is important, strength is important, avoiding contractures and minimizing scarring. But really the goal of all of that is to promote independence and making people more functional. If a patient has 60 to 70% of their body burned and they can heal with grafts and everything, but they can't move their legs, how are they going to walk? And how are they going to interact with the world? How are they going to get back to their lives? So one thing I really want to talk about is rehab is the job of the entire team. I think that's really important to speak to all of you about because not everyone in here is a physical therapist. When I go to see a patient, I'm in that room for maybe 30, 45 minutes out of their 24-hour day. But rehab doesn't just happen with me. Rehab needs to happen. The patient needs to be involved. The providers need to be involved and set that expectation that the patient needs and the family may need to do some work because that 30 minutes that I'm seeing that patient is not enough. How many times do you move a day? Move all day, right? But these patients aren't moving one bit. So it's not just that 30 minutes that we see them, it is really an all day thing. As Amanda talked about, pain relief is key. You're not going to get your patient to do anything if it's excruciatingly painful. You don't want to move. You're not going to do something. If I'm pushing that patient through their pain, they're going to say, I'm not seeing you anymore. I'm not doing that. So pain relief is really key with these patients. And then again, with education, setting that expectation, not just the therapist coming in and saying, oh, it's time to move, but the physician and the nurse saying, you need to do this all day long and participate because that's really how you get back to your life. All right, so timing of an initiation of therapy services, to be honest, as soon as possible. Obviously, we don't want to see them in the resuscitation phase, that is too early, we're still saving their lives. These people are saving their lives at that point. So it's a little too early. But we really want to get in there and start as soon as possible. Even when the patients are intubated and sedated, they still sometimes need us to come in and make sure we're doing range of motion. Tomorrow may be too late. These patients can contract and seize out really, really quickly, and it can happen in a matter of days. So we really want to get in there as soon as it's medically feasible. And then a lot of times these patients will have multiple surgeries for skin grafting. And so when do we restart therapy after that? Well, it depends. Is the skin graft a temporary covering, in which case you could start moving pretty early after that. If it's not, if it's a permanent covering, you may not want to start right away because you want to make sure that that covering and that graft is adhered sufficiently before you start moving. Feedback just a little bit. And that's going to be determined by the surgery team and how it looks. One thing I really want to point out here is prevention is much easier than treating something. If someone develops a contracture, it is really hard to treat, but preventing it is about 10 to 15 times better. So, and that's why we get in there early, so we can prevent these. So contractures, what are they? It's just an abnormal shortening of any muscle or surrounding tissue of a joint that decreases that range of motion. It may end up leading to the tightening of the joint capsule, in which case you're going to probably need surgery to release that. So we really want to get on this early. And why it happens, there's a whole lot of reasons it happens. We don't move, the duration of the mobilization, sometimes just soft tissue or bony pathology that's happening in there. There's a lot of reasons that can happen. And there's a lot of risk factors for it. If a patient is sedated, if they're not aware, if they're not moving at all. The location of the depth of the burn is really important too. So if it's not crossing a joint, you're not as high risk of a contracture. And then obviously you're going to have some increased risk for medical problems and functional deficits. So you can see the hand on the left side here, it has some contractures in it, and it might not be possible for them to even grasp or spoon. But after the release of that and range of motion, that patient might have full range of motion and be able to grasp that tool. Most common locations, you're going to get them pretty much anywhere, and specifically if you do have a burn that's crossing a joint in any location, that's going to be at a higher risk. These are some of the common ones with the upper and lower extremities, and obviously they're going to cause issues with communication, hygiene, self-care tasks, sitting, even just sitting, standing up and walking. So what do we do to prevent contractures? Well, we position and we splint. And again, that is not just something that therapy does, that's going to be something that everybody does. So this is also going to help manage the swelling that the patient has. It helps out with in a good position for wound care and can prevent some peripheral neuropathies. So patients are going to tend to a position of flexion. So when you're uncomfortable, what position do you get? You curl up in a little ball, right? And deflection. Well, that's what these patients are going to do. Our flexor muscles tend to be much stronger than our extensor muscles as well. So even if they're not conscious or aware, those muscles are just going to start to tighten. So we do want to position them in more of a position of extension, because that's going to make sure that when things heal, it starts healing in an extended position and not in a flexed tight position. The other thing we'll do is splinting. So you can see with the ankle, we want to keep it in a neutral position. When a patient's lying in bed, gravity's going to bring that ankle right down, right? And if they stay there for more than a couple of days, that ankle's going to get tight, and then they're not going to be able to stand up, because that's the position that your foot is in when you stand. So if that gets tight and they can't do that, they're not going to be able to stand up. So we're going to position that ankle in a neutral position with whatever we have, so that we don't get that contraction. So you don't often have to splint patients if it's a superficial wound, right? If it's a superficial burn, that's going to heal and it's probably not going to tighten up. But when you're starting to talk about those deep, partial, or full thickness burns, and they're unable to achieve that range of motion, you really do want to splint. So I want to point out the picture on the left over here. So that person probably can't reach their head even. Raise their hand over their arm, reach something on a cabinet. And that is actually completely preventable by positioning something. So the guidelines that we use initially, we'll try 2 hours on, 2 hours off with skin checks to make sure that we're not causing any pressure issues and the splint is in a good position. And then they'll have it on at night. You progress to different things depending on what the patient can do and how it looks. So sometimes during the day, you'll have them do active range of motion if they're awake. So actually moving on their own, which is much better than holding them in one position if they're able. And then you really adjust it based on your observed changes. Just like anything you do, if you see that it's starting to tighten, well, you're gonna probably want to sleep for longer. If you see that they're getting still that full range of motion, you might scale back a little bit, not do as much. Key points is you want to avoid splinting 2 consecutive joints, because that will increase the tension on some nerves and cause some nerve injuries. If I'm splinting an ankle in a dorsiflex position, I want to have a slight bend in the knee, because otherwise I may cause a nerve injury that puts them foot drop. And then obviously we want to ensure not just sprinting, but active range of motion in an exercise program or passive range if they're intubated and sedated, because that's going to promote and keep that range of motion. So we do recommend range of motion quite a bit. So passive when they are not able to move themselves, and that can be done by the family, that can be done by the nurse, that can be done by the physical therapist, that can be done by the physician if you go in and talk to the patient. So what do you all do when your shoulder is uncomfortable or your ankle's uncomfortable? What do? You move it, right? You move it or you stretch it. Oh, my calf really hurts. I'm going to stretch that and feel better. It makes the patients feel better to move. And so even when they're intubated and sedated, sometimes range of motion can be painful, but it can actually help their pain and can make them feel better. Once they're able to, we want to choose functional exercises as their range of motion, especially with kids. A kid is not going to do 10 arm raises when you tell them, right? They're 5 years old, they're not going to understand that. So we just choose other tasks. Throw the ball to them to make them raise their hand up, or reaching for some toy that they like. So we're choosing functional things because we don't move in this way, right? This is the way that our arm moves, but that's not the world we live in. We live in this world here. We live in 3 dimensions. So you want to choose functional exercises because that addresses all our range of motion. Guidelines for range of motion is best performed in time. That just helps prevent range of motion limitations from positioning. You're going to support the joint. You're going to let it off. If you're trying to move one joint, you want to make sure you're supporting the joint above and below if possible. You're going to take it all the way through until you feel that resistance, and then you can stretch in that position. And you don't want to push it past where it's going to go. Push it too far, it can cause pain and it can cause more issues. I like to tell people all the time, range of motion is not necessarily gentle, but the frequency is almost more important than the stretch that you get at the end. You do want to stretch, but the frequency that you do it is more important. You're not going to move quickly. You want to do a slow, prolonged stretch. You're not going to quickly move it into that position because that can cause some issues as well. It's not going to be effective. And then most importantly for you all is to use good body mechanics. Legs are heavy, right? A patient can't help you. Legs are very heavy. And if you bend over your back and try to do it that way, you're going to start hurting your back and then you're not going to be able to help anyone. So please use good body mechanics. Usually we do this every 2 hours. And then for about 15 to 30 seconds, because any stretch longer than that really doesn't make much of a difference. It doesn't matter if you stretch 30 seconds or 5 minutes, it's really about the same. So it actually doesn't take very long. And you only have to do a few repetitions with that stretch. All right, so I'm not going to go anywhere, but I want everyone just to stand up. Stand up. We've been sitting for a long time. Stand up. Move your feet. Stretch your arms if you need to. Good. Good. All right, have a seat if you like to. You can stay standing if you feel good that way. I don't care. So that took about 10 to 15 seconds, right? Do you feel more awake? You feel better? You've got your blood flowing. Our patients need that too. They're in bed all day long, right? So they want to move. Bodies are meant to move. They're not meant to lay in bed, and they don't work well when they lay in bed. So bed rest is bad. I know some patients have to be in bed. They have to for various reasons, but bed rest is not good for you. So we really, and these are all the things that it causes. We know it's bad. You're going to lose nearly half of your normal strength in 3 to 5 weeks of immobilization. So if you had to immobilize your ankle because you had an ankle fracture and you had to keep off of it for 6 weeks because it was still healing, you take that cast off and your leg is very weak and very stiff. So it happens quickly. It actually only takes a few days. So we really want patients to move as much as possible. There are bone changes and cardiovascular changes that happen very quickly. And again, if you learn one thing from this presentation, it is that prevention is much, much, much better than treatment. It's harder to treat something, much easier to prevent. Something that we'll do for mobility is we do wrapping and compression. And there's a few reasons we do this. A lot of times when the early stages for patients with burns, it helps with their pain. So a patient will get up out of bed, they'll have a skin graft, they get up out of bed, and they put their leg down, and it hurts. It hurts a lot because all that blood is rushing to that leg, and it's starting to swell and it's painful. And sometimes at that point, the patient says, "I'm not doing anymore. I need to get back in, but it's very painful." Well, if we wrap it, that decreases that. Or, and the other thing is that if you start to get up and move, inevitably, this happens all the time. 2 minutes later, they're starting to walk and they say, "Oh my gosh, I feel better." It really hurts to sit up. So some of this wrapping is for that pain control. You're going to apply more pressure down at the foot than you are at the upper leg. And you don't want to apply the elastic bandage or A-strap directly to the burn or the graft site. You want to put some kind of gauze or something in between. Scar management is another big thing, and this is a big contributor to contractures as well. So scars, they take the shortest route possible, and I think that's the key. That's one of the reasons he's positioned in this splint. And the picture I showed you earlier with that boy with the arm down there, that scar is taking that shortest route possible. So we can make sure to continue that range of motion and that positioning. We can prevent the scars from doing that. You know, sometimes there's hypertrophic scars. You're going to get that really big bulky scar, and that could limit the motion. And another thing in terms of scars, because it takes 4 to 6 months for them to really heal, they can be discharged from the hospital and they have great range of motion. And guess what? They don't do their exercises at home. They don't continue it, and then all of a sudden they come back 2 to 3 weeks later and they don't have great range of motion and they start to get contractions. Again, it's that education to the patient and their family that this is not just a one-time thing, it's an ongoing. All right. I just want to point out on this slide mostly that there's 3 important techniques that we use for scar management. One is silicone, and we'll talk about that. I don't know if you guys have access to that here, but it's something we use not all the time, but sometimes for patients. Pressure therapy or compression, which I briefly touched on before, and then scar massage. So silicone will be used, and typically in our world, we would recommend this for more of the burns that are more visible, like the facial burns. The mechanism is not really well understood, so I don't know if anyone knows more about it, but the research that I've seen is the mechanism is not really understood. It's most likely affecting the collagen remodeling, but basically it's going to soften the scar, flatten the scar, increase its pliability, and it doesn't need pressure to work. You just have to lay it off, which is really nice. Now you're not going to use any of these techniques until the scars, the wounds are healed. So you're not going to be using them early on, but it's definitely something to use once they're healed. So pressure therapy for scar management as well. We talked about A-straps and a few other techniques. That's early stages, and that doesn't just help with the edema, but it helps with that scar to make sure it doesn't become hypertrophic and decreases the swelling and itching from it too. They can be really, really itchy. The patients don't feel that well. They, so you're going to start this as soon as the wounds fully close and they're able to tolerate the pressure. Sometimes they're very sensitive. They have hypersensitive skin after grafting and can't tolerate this. And the other part of this though is the wear schedule. They've got to wear this a lot, 22 to 23 hours a day. That's a lot, right? They're only going to take it off for washing. And it's something that it's not necessarily a good thing for all patients, because you have to know you're going to have a compliant patient and someone who's going to follow up on it. So scar massage is the last thing that we'll discuss in terms of this. These are a couple techniques that we use. Again, the scar needs to be healed. You're not going to do this on something fresh, right? That's not okay. But you can start these, and what this is going to do is mobilize that skin as well. Scars can bind, right? You're going to have it, they can adhere to the tissues below. Your skin moves on top of all that. You want to make sure that that happens. Again, it tightens up and adheres. You're not going to get good range of motion in the joints at all. So these are just a couple techniques that we use. We use a little bit of non-sensitive motion with this and just go in a couple patterns to make sure that we're breaking up any adhesions. In the later stages, there's some techniques that we can use. Patients can be really hypersensitive, right? If those nerve endings are, in essence, they're burned and they regrow a little bit in there, so they can actually have some really the way that we treat this is by basically habituation. We have to progressively go from slightly irritating touches, which may be just that feather, to more irritating sensations. And they just have to basically start to be able to tolerate that. It's not a fun process, but it actually helps. If they can't tolerate any light touch, they're really limited. And by the time that they go through this, they might be able to actually tolerate clothing on that. That's it. All right. Any questions?
I've been in emergency medicine for 24 years and emergency trauma for the last almost 14 years. So we're going to go over some pediatric trauma. Injury remains the most common cause of death and disability in our pediatric community. Locally, it would be motor vehicle accidents, either inside the car, outside the car, hit by the car, or anything like that. So, we're going to identify some the priorities in the trauma assessment in pediatric patient, which is the same as adult. Describe appropriate interventions with the management airways for feet, which tends to be a lot more difficult than adult because of the anatomy of the pediatric patient. Recognize some of the most common cause of cardiac death in pediatric patient. How to obtain IV access tends to be a lot more difficult with peds than it is in adults. Their veins are a lot smaller. Like I said, their anatomy is different than adults. And determine drug-loaded and blood dosages in peds, which is always based and very different than it is in adults. And identifying non-accidental trauma, abuse cases, things like that. So we have a 3-year-old boy who fell 10 meters out of an apartment window coming into your facility. So a 3-year-old is about what, 1 meter high, maybe, 10 times the size of a pretty significant mechanism. His GCS is pretty low. He's only opening, does not open his eyes. He's only roaming and extending abnormally when stimulated. When you're touching him, he's taking his arms out, going out more of a posture. He's not responsive when he comes in. His feet are unequal and his vital signs are very low. So blood pressure is over 57, heart rate of 166, and he's breathing at 49 times a minute. Model extremities, all that. So what the priority is identifying, pediatric injuries, their assessment. It's going to be the same as adults. You're going to go over your airway, breathing, circulation, disability, exposure. Airway with children, it's much more different. It's funnel shaped. It's the bottom is more interior. You can't feel the rectifier membrane. It's very soft. You're intubating. You have issues with you can't put chronic pressure because it's too soft. You'll pull out the airway. The airway is funnel shaped, so it tends to be a lot more smaller. Getting airways are very difficult with patients. So like I said, his blood pressure 74 or 57, heart rate 156. That's low blood pressure, high heart rate, breathing at 49 times a minute and with oxygen at 85%. So what that's telling us is not getting enough oxygen into them. We have to figure out why, but his breath sounds are symmetrical. Most common cause of cardiac arrest in children is going to be breathing. It's their airways either opening up or they're not ventilating. But it's almost always a lung issue and not a heart issue. Go back to airway management. So you put high flow oxygen on a patient, they're still static low in the 80s. You're going to want to, try to put an OPA in the patient. You put the OPA in, still static low. You try to intubate the patient, you can't get an airway. The next best thing you're going to do is a needle cripe instead of a surgical cripe because of the anatomy. They don't recommend doing surgical cripes. It's too close to the thyroid. And based on the vital signs with the blood pressure being low, the heart rate high, respiration's high, would you guys consider this a sick patient? Yeah, you guys think he's in shock? Yeah, now we gotta determine what kind of shock. He's got mottled skin, low blood pressure, high heart rate, we're thinking hemorrhagic, right? We also have to think other types of shock, but hemorrhagic is probably the most. After intubation, or after unsuccessful intubation, you're gonna try the needle. So we've already gone over the airway about the needle, sorry. So IV access to the patient, pediatric patient. You want to gain, you guys do central lines here. We do IOP, which is a needle going into the bone. We have access large core needle into the humerus and a small one into the tibia, but I don't know if you guys do that or not, but what you can do, if you can't gain large core access in pediatric patients, they're anacubable, you look for anything. You get a small needle, you look in their hands, you look in their feet, some of them you can look in their scalp. You can see the vein, you can feel the vein, get some kind of access, you can start to fluid resuscitate them, and then once you start doing that, then you'll be able to start, feeling more vascular access that you might time to get to your central line. For fluid resuscitation, it's always going to be, you're going to, if weight goes, the weight on the child, you can either ask the parents if they don't, if the patient's losing a bit of weight, or if you have a weighted gurney, Roslow's tape will tell you what their average weight should be. And then also you can go by their age. You're going to go 2 times the age plus 10, and that's going to give you an idea of what their weight should be. All of our medications, fluids, bloods, everything else is going to be weight-based. Fluid resuscitation, you're going to do 20 milliliters per kilogram, and then blood, you give 10 milliliters per kilogram, and you're only going to go so much fluids, you're only going to give that first bolus of fluid before you're going to want to switch over to blood anyway. How we're going to manage the hypertension and the fluid regimen of the patient. So like I said, you're going to give isotonic crystalloids like normal saline or LR. We don't usually give LR for suspected head injury. And then immediately go with the blood because you don't want to hemodilute the patient by giving too much fluid. And the blood's going to be uncross-matched, of course, so you go with an O negative. With male patients, you can go with an O positive. Heart rate's come down, blood pressure's gone up. Chest X-ray shows pulmonary contusions. What do we know about pulmonary contusions? They blossom, so that's why his O2 stats are low. We need to have the oxygen on him, keep him on there, and then know and expect that it could get worse the next day. So you gotta be very careful with ventilation management on those pediatric patients. Also, with pulmonary contusions, in the absence of rib fractures, their bones are pliable, very soft. If you see a rib fracture, that is a significant impact. That is a very significant force to break a child's bone when they tend to bend first. So you have to consider that. If you start seeing fractures in children, you've got to understand that there's like the mechanism can probably be worse than what the story is. Another thing to consider is the inconsistencies with the story that parents are telling you. They said he fell, but you're seeing if he has got a fractured, healed fracture, left arm, and then CML lesion. And you know, CML lesions are usually from abuse. It's, you know, the tearing and impact and everything else on the growth plate that is, you know, is a constant thing. So twisting, pulling, you know, things like that, we're gonna think abuse. And so did this kid fall, or was he pushed? Was he just beaten? If you guys suspect child maltreatment, we have child protective services in the United States, and maybe you guys have something called human right. So you call them, you get them involved, you let them know what the story is, the injuries to the pediatric patient. And then of course you're going to transfer to your pediatric receiving trauma hospital or whatever hospital it is that take care of. I think you guys could take care of each year at this one, but you would expect other facilities to maybe send you their sick kids to take care of them. And we don't usually do, like, so the kid got a spleen injury, that was the, you know, the hypotension, tachycardia, the hemorrhagic shock. Surgery is not usually recommended. You're going to do serial abdominal exam. You're going to check the CBC and make sure their hemoglobin hematocrit are staying within normal, and constant vital signs and skin signs. I always tell people skin signs don't lie. If your patient's pale, cool, diaphoretic, you're losing blood somewhere, and that's going to go with adult organs. Any questions?
Okay, next we're gonna have Cindy Rivera, another trauma nurse from our hospital. Cindy.
Good morning, everyone. Thank you for having us. We're really excited to be here and share our knowledge here with you. I'm going to be discussing trauma and pregnancy and my partner Violet. So all of pregnancy causes operations with normal modality and response to injury due to the patient. The sequence of the initial is the same as with any other patient. So we need to recognize the approach. So we need to recognize the approach to the care of a pregnant trauma patient. And with them, it's still the same. So even though they're pregnant, you're just taking care of two patients instead of one. The approach is still with the ABCs, primary, secondary. We need to identify the physiology changes in pregnancy and the impact of this on the successful resuscitation of the mother in the pregnancy. Determine the management priorities regarding the mother and fetus in the trauma case scenario. So we treat the mom, we treat the baby, right? So the primary focus is going to be on the mother by simultaneously caring for the fetus. Identify when to administer the RH therapy. So in the trauma patient, if the trauma is located in the primary area, that's when we're going to administer the therapy. We're not going to do it if it's like on their legs, but when it's in the midsection, then we're going to have to be sure to administer that. Recognize the signs of intimate partner violence and its potential to cause injury of a pregnant trauma patient. So we basically need to just find out, you know, when the patient's there, does it sound like it's happened? You know, if he falls, are all the signs and symptoms, are they correlating? You know, are they the same, or have they been here a lot? We've got to determine if this is new and old. In this case, it's a 35-year-old female. She was transported to the ED. Husband reports that she tripped when she was walking down the stairs. Upon arrival, she was unconscious. And she was in spinal restrictions on the board. Okay, so how might the patient's pregnancy affect the performance of the primary survey? In this case, she's in her second trimester, right? So how is a pregnant woman in the second trimester? Has anybody ever been pregnant here, delivered a child? How did you feel when you were pregnant? How did you breathe? Were you able to breathe with the baby way up here, forcing all your lungs and all your intestines to be at the top? No. So when women are breathing during pregnancy, it's rapid, it's shallow. So we need to remember that when we're doing our ABCs. Blood volume. So in pregnancy, blood volume is significantly increased, 1,200 to about 1,500. So we need to pay attention to that because we need to pay attention to their vital signs. They're a little tacky to begin with, normally just being pregnant, but if that number comes in and it's high, which with her, we're not there yet. So with her, once you see it's tacky, it's already kind of late because they don't show any kind of signs and symptoms with their vital signs, and they could already have lost that 1,200 extra blood they already had. So once that vital sign starts, with the tackiness, it's kind of like we're already behind, right? Because they already lost a significant 1,200 is a lot. Okay. And what additional information would we like to know regarding the negative injury? So he said she fell down the stairs. Well, what did she fall on? Was it concrete? Was it carpet? Did she hit her head? Says she's unconscious. So there's just certain things we want to know to find out, if she hit her belly. Okay, so we get her back and we put her on some high flow oxygen. She's not able to respond to any questioning. These are her vital signs. Her respiration is 28, her heart rate is at 130, blood pressure 110 over 50, her GCS is 1, 2, and 4. Is that normal? No. Her heart rate's already too fast, her GCS is really low. So now we have to treat her like all the other stroke patients, airway. So is she maintaining her airway? What should we do to make sure she maintains her airway? We need to intubate, right? So with this patient, airway, we intubate. All right. So that's the A. So like I said, when you're pregnant, what happens? Way up here, belly, you're nauseated, you throw up easy, right? So any chance we get, we want to hurry up and get an OT in there because they're going to aspirate. We want to prevent that. All right, so we kind of went over the breathing already. We already know that they're shallow. So we're listening to her breath sounds, know that they're not going to be big breath sounds like we can do because we have all the road, right? All right, so also remembering if she does need a chest tube. Since everything's pushed up, it might not be the same anatomy as a normal person, right? Because it's pushing everything up. So you might have to go one higher. All right. So instead of going to we'll probably have to go to the fourth instead of the fifth, right? We have to obtain IV access, probably too large for, because if she's happy, we're gonna have to do something about that, right? Probably start some fluid, maybe anticipate giving blood, we're not sure yet, right? Well, assessment and management of the mother continues. Which steps should we take to evaluate the fetus? So we already put her on type of oxygen. That's really good, right? Because oxygenate mom, you put oxygenate baby, right? Okay. So we already discussed that we need to take mom. We take care of mom. We take care of mom, we're taking care of baby. But as soon as we can, we need to get OB involved, right? Get some nurses in there.
possibly get them to start monitoring the fetus. So the patient undergoes some drug-assisted intubation. Of course, we're going to try to hurry up and get that OB in there. These are the vital signs: 130, blood pressure 90/60. To help with that heart rate, we're going to get that IV and bolus started. And then we're going to displace the uterus to the left. Why are we going to do that? How do you feel? When you're pregnant, you're laying on your back with a big old belly on you. Can you breathe? No. And also, it compresses your venous, right? So we want to put you on your left. Then you can go ahead and have a better blood pressure. All right, so we give that fluid. Her heart rate is now 100. Was that responsive to fluid? You probably needed that, right? We go and take her to get a head CT. We see that she has a contusion, moderate amount of subarachnoid blood. We called the neurosurgeon and his decision to transfer to ICU. On physical examinations, they noticed that there was multiple bruising. They did the chest X-ray, other X-rays, and they noticed multiple fractures both ways. So that's high suspicion of abuse, right? So I was told that the human rights, you guys have the human rights, we have social workers, we have adult protective services that we get involved. Okay, so we're going to talk about this a little bit. What makes you suspect that this partner could be harming this mother? So we're going to talk about the fractures. Those aren't normal, they were old. And so we went ahead and got special, what was it called? Your human rights involved. We repeated the CT scan 24 hours later, no worsening findings. The decision to lighten the sedation and see how she reacted, see if she's able to be extubated. She woke up and she was extubated, remained confused for about 7 days, but she recovered in 2 weeks, delivered a full-term baby by C-section. We already went ahead and got social services involved, and police charged her husband with assault. Basically, we had this review. You guys remember, we still got to do our ABCs, primary and secondary, from head to toe. Make sure we pay attention to and monitor her and baby continuously. Even though she, some patients will come in and they look fine. Later on, it might be something different. So we need to pay attention to her and baby. Sometimes when we monitor baby, we notice that heart rate's going down a little bit. That might mean something's going on with mom, because that means the oxygen is not getting to baby, right? So his heart rate starts going down. So we need to pay attention and see what's going on with mom that's expecting the baby. Now we already discussed that, or we need to administer that unless injury is remote to the. We need to administer that when it has anything to do with the primary part of the body, not this extremity. And then discussing intimate partner violence, a major cause of injury in women at all times during their lives, and should always be considered, especially when the story doesn't fit. And for like nurses, those of us who treat women, there's a lot of factors in it that, the husband is real close to her, won't leave her alone. Just pay attention to all the cues and try to get that mom by herself and try to find out what's going on and help her feel safe.
Thank you. That basically completes the end of our trauma portion of our lecture. So for today's section, pediatrics and pregnancy, the most important are these patients are a little bit different. Pregnancy, you got another life inside you. But most importantly, though, for people that relies on someone else to take care of them, you got to be wary of possible non-accidental trauma, basically abuse for children, or spousal trauma, or spousal abuse when it comes to pregnant patients. And our final lecturer will be Ingrid Martinez. She's also a nurse in UC San Diego and give a special lecture on breast cancer.
Good morning. My name is Ingrid. I am an ICU nurse at University of California in San Diego. I also do recovery room at another hospital in San Diego. A little bit about me. Prior to that, I've been in the healthcare for 10, 15 years now. So we're going to talk about breast cancer. Here, I know that our Excellency, Ms. Bessie, she was a breast cancer survivor, so we wanted to do a little bit about breast cancer for her. So I did some searching here, because breast cancer is the leading cancer for death for women in the world, period. And in Nigeria and in Africa is a really big deal. Breast cancer tends to be more common in younger women in Africa than it does in Western countries. So in our country, in the United States, it's mainly an older population. Here it tends to be on a younger, premenopausal females. Nigeria has 80% of breast cancer mortality rate, and two of the big things are awareness and treatment. So I think that's really what I'm going to focus on, since you guys are the nurses, the doctors, the healthcare providers, to teach them. You'll see women when they come in and see you. Teach them to do a self-exam, teach them what are the risks, and kind of take the stigma out of it, out of the teaching. Okay, so attributing factors. Many women delay seeking medical attention until the tumors are way advanced, and usually is when the tumors are in stage 3 or 4. So they've been advanced. A lot of female, and I know in your culture, you go to home medicine and home medicine before you come and see a doctor. So you have to teach them to come to the clinic, to the hospital, to get a self-exam, to look at the differences, and we're going to the other risks and symptoms here. I guess, let's see what else. A lot of people travel long distances to come to clinics, so that also affects from them getting treatment and getting help. I guess way to help detect self-exam, mammogram, having a questionnaire, making sure that you ask them if anybody else in their family has had any symptoms of breast cancer, has had any history of breast cancer, and their both sides, their mom or dad side, anybody has had cervical cancer, because those can correlate as well. And ultrasound, I think, is the biggest way you guys check here. And in the US, we also use ultrasound, we do mammograms and ultrasound. But that's a way to see whether there's something that's not normal there, get a biopsy and things like that. Signs and symptoms of breast cancer are a lump, thickening in the breast area, changes in the size of the breast, the appearance, the type of the skin, if it gets kind of like shiny, if there's discharge, if there is coloration, like even bruising, that's never normal. If there's any peeling, sealing, crusting around the nipple or just in the breast area or around the arm, pretty much are doing it down all over on both sides. A lot of women to check when they're taking a shower in the morning, maybe once a week. When something feels odd, just come to the clinic, see you guys, tell the nurse, tell any healthcare provider that can refer them to the doctors and to everybody else. This is just more kind of like a different thing you can see, not the best picture, sorry, but swelling, the dimpling, the lymph nodes, the changing in the armpit. So just everywhere from the armpit down around, kind of what you want to check, show them. And then I guess once it's detected, the best way to seek is care, right? So I know a lot of times here you guys do mastectomies, and I read and what I found was a lot of women don't want to come seek help because they're scared to get a mastectomy. They're scared of the way they're going to look later on. They're scared of the way they're going to be treated. So I think the best way to improve is getting early detection. So a total mastectomy doesn't have to be done. So it can be caught on time. So it doesn't advance, so it doesn't advance to other parts of the body and spread. Yeah, I think I said everything. There are other organizations here that you can refer your patients and clients to for help, for awareness, for kind of some moral support. There's the CCG program, the Breast Cancer Association of Nigeria, the Bring Back Our Girls movement, and I guess just the big thing is removing the stigma of it, of having breast cancer, so that people can get cured, get treatment, and spread the awareness. And that's just thank you for having us here. Thank you to Your Excellency, Ms. Betty. This is her 25th anniversary of being breast cancer free. And I guess from our team, thank you for just being so welcoming to us and having us here.
Thank you everyone for attending. We really enjoyed doing this for you. And we are going to be doing some skills later. This is, if you're interested in giving us an evaluation, we only want to make everything better. So if this is the QR code, you just go online and give us a rating or maybe leave some comments. That would be great. But we really appreciate your attention and you welcoming us here. We're going to take a brief break while we set up our stations, and we're going to have 9 skill stations that you're all going to rotate through, and this is going to help with the ACLS and the ATLS portion. Okay, thank you.